Okay, hi everybody. Okay, I'm Dr. Robert Hauser. I am professor of neurology at the University of South Florida. I have been at the University of South Florida for, fill in the blank, 37 years. Ooh, yeah, that's what I say. All right, guys, so I'm going to try and build on Adolfo's excellent talk about the basics of Parkinson's disease, and I'm going to talk about where we are now and where we need to go into the future from a scientific basis. So the title of this talk is Parkinson's Disease into the Future. They're my disclosures. They really don't have any relevance for this talk. And what I'm going to cover is the contemporary view of Parkinson's disease, the biological basis, Parkinson's disease tests, both in research and the clinic, and where we need to go from here. So let's start with the traditional view of Parkinson's disease. And to do this, I want to take you back to when I was in medical school in the 1970s. Here we go. So this is what it looked like. And this is what my professors taught me. So we still, as you heard earlier, diagnose Parkinson's disease based on what the patient tells us and the signs that we see. What do we see? Well, we're looking for tremor, which is shaking back and forth, slow and small movement, and stiffness. That's the basis of our diagnosis. And my professors taught me that Parkinson's disease was related to a loss of dopamine neurons. In this picture depicted in red, they go from the middle of the brain up to the blue area, and that's where they deliver dopamine. And it turns out that one loses about 50% of those dopamine neurons, and dopamine in the brain is reduced by 50% before one exhibits those signs of Parkinson's disease: slowness, stiffness, and tremor. And the other thing we knew back in the 1970s was if a person passed away and you took their brain and made slices and looked in those remaining dopamine neurons, you could see these things called Lewy bodies. And if you see sort of those pale areas and that dense core, those were called Lewy bodies after the pathologist who discovered these in 1912. And so these were just a marker of the disease. If you had this, if you had loss of dopamine neurons and you had this picture in remaining dopamine neurons, the pathologist would say, yes, this person had Parkinson's disease. And we didn't know what this was. It was just looked like a little clump of protein that was left inside remaining dopamine neurons. And that's what they taught me. That was the Parkinson's disease lecture. Now, in the last 15 years, as Adolfo has mentioned, we've learned a lot about non-motor symptoms. And he mentioned people get loss of smell, constipation, fatigue, sleepiness, sleep disorders, depression, anxiety. And I do admit that even back in the 1970s, we did know that patients with Parkinson's disease, years after diagnosis, 10, 12, 15 years down the road, often got cognitive dysfunction, that is, problems with thinking and memory. And that was sort of it. That's what they told us. Give medications to bump up dopamine, and that's what we could do. So let's move on now to the contemporary view of Parkinson's disease. So I'm going to tell you that tale, and here we go. So this story begins here in the Contorsi area of Italy. And our friend Larry Golby, who worked in New Jersey at the university there, he and his colleagues discovered this family. And this family was very unusual in that a lot of individuals in that family had Parkinson's disease. Now, Parkinson's disease only rarely is familial. It only rarely runs in families. But they discovered this family that through 11 generations, 60 individuals out of 600 had Parkinson's disease. So this was quite striking. And Larry gathered this information, and ultimately they sent 20 blood samples to the National Institutes of Health, and that group did an analysis on those genetic samples, and they found a mutation in what's known as chromosome 4, the long arm of chromosome 4, and they were able to figure out that this was a mutation in a chromosome that coded for a protein. The protein was called alpha-synuclein. And this happened, if I remember, in 1996. So we all said to ourselves, hey, did you ever hear of alpha-synuclein? We all said, no. Do you know what alpha-synuclein does? No. And even today, we don't really know what alpha-synuclein does. But just imagine, here is this family, and they found a mutation who has Parkinson's disease, and in individuals in that family have Parkinson's disease, NIH figured out they have a mutation in the gene that codes for the protein alpha-synuclein. So you would say, aha, here's the cause of Parkinson's disease. So let's test everybody else who has Parkinson's disease, not in that family. What % of people do you think had that gene mutation? 100, 90, 80, 70, 60, 50, 40, 30, 20, 10. Adolfo, tell me when I get there. 5, 4, 3, 2, 1. Less than 1%. It's very, very rare. There are only a few families in the world who have that mutation. So a mutation in the alpha-synuclein gene is not the cause of Parkinson's disease. However, well, before I tell you that, I'll tell you one other interesting thing. Bill Clinton mentioned in a State of the Union address how wonderful NIH and science is. It only took NIH a couple of weeks to do this genetic analysis, and that's pretty amazing, and that's what Bill Clinton was commenting on. But Larry Goldby told me, hey, NIH only took a couple of weeks, but it took us 11 years to characterize this family, to map out the family picture, the family tree, and to figure out who had Parkinson's disease or not. So I thought that was kind of interesting. So there's another little tidbit. Well, anyhow, these families are very rare that have this mutation in Parkinson's disease, but other investigators said, well, wait a minute, let's make a stain so we can identify this protein in the brain. And they found that when they did that and they applied it to brains of people who had slowness, stiffness, tremor, and were diagnosed with Parkinson's disease in life, guess what they saw? Remember those Lewy bodies that I said were first discovered in 1912? Well, it turns out that when you use this stain, those Lewy bodies turned out to be chock full of alpha-synuclein. It's a big glump of alpha-synuclein. So even though most patients with Parkinson's disease don't have a mutation in the alpha-synuclein gene, something's going wrong with the protein alpha-synuclein in just about everyone who has Parkinson's disease. And there was a pathologist then who said, okay, that's interesting. Let me use that stain and take all these brains in my pathology lab, and I'm going to stain these brains with alpha-synuclein stain. And I'm going to sort of put them in order from the least amount of alpha-synuclein staining to the most. And that'll kind of tell me, how does this change over time? That was his assumption. And what he saw when he looked at the brains with the least alpha-synuclein, but it was there, he saw that there was some of that alpha-synuclein in the smell nerve and at the bottom of the brain. And you can see in the slide here, the arrows indicate the more alpha-synuclein staining he saw, the more he saw it go up the bottom of the brain, up to the area where the dopamine neurons are, the midbrain, that he called stage 3. And then ultimately it would go up, and when there was a lot of alpha-synuclein staining, it would get to the top of the brain. So the more he saw, the more it looked like it went from the bottom up to the top. And the top made sense as being a late area because the top is where thinking and memory occur. And remember I said, even back in the 1970s, we knew that was 10, 12, 15 years from diagnosis. So Brock made this hypothesis. He said, I think it looks like this problem starts at the bottom of the brain and in the smell nerve, and then it moves through the brain the way these arrows are depicting it. And we at the University of South Florida sort of stumbled into this story in the year 2008. We were interested in whether you could transplant fetal dopamine neurons into brains of Parkinson's disease patients and use that as a treatment. The idea was you could implant them into the area where dopamine neurons were being lost. Hopefully these transplanted neurons would live, they'd make connections, and they'd pump out dopamine in a normal fashion to restore function to Parkinson's disease patients. And what we found was that you could do that. The dopamine transplanted neurons would live. We didn't really prove that it helped patients, but a couple of our patients did pass away 14, 15 years later, and when we looked at their brains, what we saw was this. When you looked in those fetal transplanted neurons who are now 14, 15 years old, we saw clumps of alpha-synuclein in there. So what does that mean? The Parkinson's disease problem had moved from the patient's brain into these 14 and 15-year-old neurons. Well, that was amazing. 14 and 15-year-old people don't get Parkinson's disease. So this told the scientific community that this Parkinson's disease process could move from neuron to neuron. And this then was recognized by people who were working in the field as this process. It's known as a Prion-like process, but the idea is you have a protein and it misfolds, and when it misfolds, it gets into a conformation where it becomes very sticky, and then it can stick to another protein of the same kind. So you get these little clumps, and then the little clumps can recruit other proteins of the same kind to misfold, and they get recruited into the clump. So the clump keeps growing, but it's recruiting more and more proteins of the same kind to misfold and clump up. So it's not just the protein is clumping, it's causing other proteins like it to misfold and clump up. So it's a whole process. So it's very important. So aggregation means clumping, and seeding means it's causing other proteins like it to then clump up, to misfold and clump up. And not only that, it looks like you can have these little clumps and they can move from neuron to neuron. So that explains why Brock saw this process move through the brain. These little clumps move through the brain, and then in the next neuron, they induce more protein to misfold and clump up. And if you're wondering what it looks like, here's one way in which it might clump up. You see on the left-hand side, that's what alpha-synuclein looks like, probably in its normal form. And then you see if it misfolds and then clumps up side by side, it can form these sheets, and these sheets can stack up on top of one another. So that's what the clumping looks like. Well, how do we know that this is really important? Well, if you take a Lewy body or a piece of a Lewy body from a patient and put it into the brain of a mouse or a monkey in the dopamine area, you can see this process spreading, and then you can see that dopamine neurons are affected with this clumping process, and then the dopamine neurons start to degenerate, which is a scientific word for they're lost or they die off. So this looked like a very important breakthrough in our understanding. And this also led to the test that Adolfo mentioned. The brain is bathed in fluid that goes down around the spinal column. And when we do a spinal tap, you can get this fluid and you can use it for scientific purposes. And some of these little tiny clumps of alpha-synuclein are in your spinal fluid because they sort of leak out of the brain and are then in that fluid. So you can take that spinal fluid and put it on a dish with normal synuclein, and if you have in your spinal fluid these little misfolded clumps, they'll induce misfolding and clumping up of normal synuclein. And so this is called seed amplification assay. Think of it as a clumping assay. How much does your spinal fluid contain these little clumps, and will they induce clumping in normal synuclein from the lab? And you can see that demonstrated here. So this is a test for Parkinson's. Now, this particular test is really a research test. We don't usually use that in the clinic, as we say, but I'll come back to that in a minute and show you just how important that is. Now, once Brock said, hey, look, it looks like this process begins down at the bottom of the brain and the smell nerve, we clinicians started saying, well, what are the things that happen early on at the bottom of the brain and in the smell nerve? And, well, the smell nerve, what's it do? It smells. So people began testing the smell ability of people with Parkinson's disease. And lo and behold, about 70% of Parkinson's disease patients have decreased smell. And in fact, when people started showing up with a little bit of slowness, stiffness, tremor, a lot of them had already lost their sense of smell. How many people here have found that they've lost their sense of smell? Wow, look at that. And it strikes me as just amazing how many patients that I had seen over the years with slowness, stiffness, tremor, and I wasn't asking them about their sense of smell. And in fact, if they had told me, hey, doc, I lost my sense of smell 10 years ago, I would have shrugged my shoulders. But now that Brock showed me that synuclein clumping was affecting the smell nerve, now we could put two and two together, and we know that this can be a very early part of the Parkinson's disease process, even before the patient gets slowness, stiffness, tremor, as I'll show you. The other thing that's very common is called REM sleep behavior disorder. REM sleep, rapid eye movement sleep, that's when you're sleeping, your eyes are rapidly moving, that's your dream state. Normal individuals have a shut-off switch, so you're dreaming, your eyes are moving, but you're just laying there not moving. If you lose that shut-off switch, then you start acting out your dreams with hitting and kicking. That's called REM sleep behavior disorder. How many individuals have that? There you go. All right, so back in 1996, a sleep doc named Schenk wrote that, or reported that when he looked at men who came to his sleep lab with this complaint of hitting and kicking in their sleep and they had no other neurologic problems, when he followed them over the years, he reported that 40% went on to develop Parkinson's disease. We now know that that's probably closer to 80% of individuals who have this go on to get Parkinson's disease. And that's because of problems down at the bottom of the brain. And when you look at it, this can occur, well, 5, 10, 15 years before the onset of slowness, stiffness, tremor. Well, what else? Well, I've only talked about the brain so far, but this clumping of synuclein takes place in nerves outside the body. Nerves to the gut are affected, and what do nerves to the gut do? Well, they make the gut work. And when you start to look at people in midlife, if they have constipation, people who have constipation in midlife are at high risk of developing Parkinson's disease. Well, is it a risk for Parkinson's disease, or is it one of the earliest signs of Parkinson's disease? A lot of these people probably have constipation as an early sign of Parkinson's disease because when you look at those nerves in the gut, they have this clumping of synuclein. So that creates this picture of years before an individual gets slowness, stiffness, tremor, they have this process ongoing in their brain and their nerves, and it may cause these problems. Decreased sense of smell, hitting and kicking in their sleep, constipation, and this can occur 5 years, 10 years, 15 years, 20 years before slowness, stiffness, tremor occurs. So in how many individuals here does this sound familiar to you? Has this happened to you? Not that many, okay. Well, it depends. It depends how close you look at it. But it also raises, what are we going to do for the future? Because remember, what we want to do is we want to try and diagnose this process as early as possible and slow it down so that individuals might never get slowness, stiffness, tremor. But even if they get that, hopefully never get things like memory problems and thinking problems. So how are we going to do that? Well, we want to find the people who have this synuclein clumping going on based on decreased sense of smell and REM behavior disorder, try and understand whether they actually have this Parkinson's disease process ongoing, and then get them treated to slow down the process or maybe stop the process. So in the future, I imagine, for example, people age 50 or older, when you go to for your annual checkup and the doctor checks your lab work and your blood pressure, et cetera, well, I think they should be doing a smell test. If your smell ability is decreased, you may already have Parkinson's disease starting in your smell nerve, and we want to know about it and hopefully get you treated. What about people who are hitting and kicking in their sleep? Well, they need to see a sleep doctor, and if they confirm this REM behavior disorder, we want to know if that's the earliest signs of Parkinson's disease and get you treated. And so what would the next steps be? Well, Adolfo mentioned the DAT scan. We can look at what's the status of your dopamine neurons. And the other thing is we have these synuclein tests to try and confirm whether you have a synuclein problem or not. I'm going to mention one other study that came out just a few weeks ago that I find just an amazing step forward. These are people that were studied who have the REM sleep behavior disorder or decreased sense of smell, and then they get a DAT scan and they have a little bit of dopamine decrease. They don't have slowness, stiffness, or tremor yet, but they're going to be watched to see how long it is before they get slowness, stiffness, tremor. And what these researchers did was they tested their spinal fluid, and they did that synuclein clumping test. And what they saw was that that people who had that clumping test, well, it turns out they developed slowness, stiffness, tremor at about 30% of them at about 5 years. But they did something more that had never been done before. They looked to see how well the spinal fluid caused the clumping. Were you a fast inducer of clumping or a slow inducer of clumping? In other words, when we looked at your clumping ability, did you induce clumping in the normal synuclein fast or slow? And if your spinal fluid and the little clumps in it were really good at inducing clumping, you went really quickly or more quickly to develop slowness, stiffness, tremor. So for those people, if you were a fast clumper in the lab, by 5 years, 35% of those individuals develop slowness, stiffness, tremor, compared to if you were a slow inducer of clumping, only 15%. So in my mind, this is a direct connection between your little clump's ability to induce clumping, this process that I talked about, and how fast your Parkinson's disease moves on. So in my mind, this confirms the core issue of this process of alpha-synuclein clumping and is a predictor of rate of Parkinson's disease. All right. One more thing. Adolfo mentioned multiple system atrophy. This is a disorder that progresses pretty quickly, and you can see that if you take the spinal fluid, it's people who have that, they induce this clumping quite quickly in that test that I mentioned. And the other thing is you can see when you look under a really powerful microscope that the way the synuclein folds and how it clumps up is different, and you can actually see this under the microscope. So these are tests that I think are coming. He also mentioned the skin test, and let me see if I can do this. What we do is we do a little skin biopsy in the neck, near the knee, and near the ankle. We send it off to the lab, and what they're actually looking for is the synuclein in the nerves just under the skin, and they actually are seeing this. And in Parkinson's disease, you see some clumping in the nerves and the skin at the neck, and a little less in the knee, a little less in the ankle. But we can use that to confirm a diagnosis of Parkinson's disease. But in MSA, this other disorder, you see more synuclein clumping, and in fact, you see a different pattern. You see more down in the leg than up in the neck. So how many people have been diagnosed with MSA in this audience, by the way? A couple. Okay, stay tuned. I'm going to mention a few more things about that. So the skin test is helping us differentiate those because of the tests we now have. So what's causing this? Well, genes are one answer, but the issue with genes is that even though we now know about 100 different mutations and variations associated with Parkinson's disease, they only account for about 15% of all Parkinson's disease. So you've heard it, the two most common are called GBA and LRRK2, but they only account for about 1% of all Parkinson's disease in the general population. It's a little bit different for Jewish individuals. They may account for about 15%. But again, the interesting thing is all genes together only account for 15%. So what about the other 85%? Well, if it's not genes, we commonly say, well, it must be the environment. And so where does the environment interact with our bodies? Well, one place is the gut. So there's been a lot of interest in, can things happen in the gut affect the brain? And so there have been studies like this where you take a little clump of synuclein and put it into the gut of an animal, like a mouse, and you can then see that process travel up the main nerve from the gut to the brain and then cause the synuclein clumping in the brain, and the animal gets slowness, stiffness, tremor. So if things happen in the gut, it can definitely travel up to the brain. And here's an illustration. On the left, here's this mouse, and you see the syringe, they're putting a little clump into the gut, and the process then travels up the nerve from the gut to the brain. The process reaches the brain, and the mouse brain loses dopamine neurons, and you can see the mouse is shaking. It's got slowness, stiffness, tremor. But if the scientists cut that big nerve from the gut to the brain, the process can't reach the brain, and so that mouse doesn't get slowness, stiffness, tremor. But the other thing that scientists can do is they can make a mouse that doesn't have its own synuclein. So even when you inject some abnormal synuclein clumps it can't induce the process. And so that mouse doesn't get Parkinson's disease-like features either. And so is there anything like that in people? Well, here's a study out of Sweden. Individuals who've had their vagus nerve, the big nerve from the stomach to the brain, cut because of GI problems, they get a lower rate of Parkinson's disease. So this suggests that some Parkinson's disease starts in the gut and makes its way up to the brain. Well, what could cause Parkinson's disease to start in the gut? I didn't tell you yet, but one genetic cause of Parkinson's disease is when individuals have too many gene copies of synuclein. They have normal synuclein, but they got too much of it all around, including in the brain. And so this just suggests that when you've got too much synuclein floating around, you just increase the risk of two of them coming together and starting this process of clumping. So just too much synuclein all by itself might cause the initiation of Parkinson's. And then some of my friends and colleagues, Denise Barbutt and Michael Zaslow, they looked at children who have an immune problem, and these kids are prone to viruses in the gut. And what they did was they looked at the gut when these kids had viruses, and what they saw was in the gut, when the kids have these viruses, there's a lot of synuclein. And what they suggested was part of the inflammatory process. When we get an infection, we try to fight it. We have inflammation to fight that infection. And it looks like synuclein is part of that. So synuclein is increased in the face of infections. And they suggested, well, when you have an infection and the body makes a lot of inflammation to fight that infection, synuclein goes up, and when you've got a lot of synuclein in one area, just by chance, synuclein can come together and start that clumping process. And in fact, other studies have shown an association between bad infections and the later development of Parkinson's disease. And when you look at it, it's not one kind of infection. It's not like this infection causes Parkinson's. It can be various kinds of infections, bacterial, viral, other. It can be in various parts of the body, brain, gut, lungs, etc. So it's not the particular kind of infection, but again, it suggests that the way our bodies fight infection, synuclein increases, and when you've got a lot of synuclein, that's when, just by chance, a couple of those synuclein could come together and start the clumping process. Well, what are we going to do about it? Well, in the lab, there are a number of ways that scientists are trying to attack this problem, and I'm just going to mention a couple ways that all make common sense. There are certain techniques that can be used, or certain therapies that can be used, just to reduce the amount of synuclein that your body makes. There's certain drugs or medications that can prevent the folding of synuclein into formations that are prone to clumping. Those are being tested. There's certain therapies that help the body clear out little clumps of synuclein before they get this process rolling downhill. Once you have these clumps of synuclein, I didn't talk at all today about how do the clumps of synuclein cause death of dopamine neurons, but there's multiple therapies that are being tested to try and prevent that process. And the medication I am going to talk about is antibodies against little clumps of synuclein. And remember, I mentioned that for this process to really take root and have an effect, it needs to move from neuron to neuron. And here's a depiction of a little clump of synuclein moving from one neuron to another. And that Y right in the middle, that's an antibody. And that antibody is grabbing on to a little synuclein clump and not allowing it to move from one neuron to the next and then clearing it out of the body. So there was a big study, or it's actually still ongoing, of a synuclein antibody called prasinezumab. That's a synuclein antibody medication. And what they did was they took patients with very early Parkinson's disease. These patients had slowness, stiffness, tremor, but they weren't yet on symptom medication like levodopa. And these patients either got placebo or the medication in the vein once a month. and we monitored how these patients did over a year. And the main outcome of the study was they didn't see an effect of the medication. But the problem is, the way they were monitored, they were looking at thinking and memory, and activities of daily living, and slowness, stiffness, tremor. And the problem there is, when you look at patients with very early Parkinson's disease, they don't have a lot of problem with thinking and memory. In fact, almost none. Same thing with activities of daily living. When people first have a Parkinson's disease, their activities of daily living are fine. So in my mind, that's not a very good way to look at progression. So if you look at the other outcomes in this study, if you just look at slowness, stiffness, tremor, what did they see? Well, they saw that the progression of slowness, stiffness, tremor was reduced by 25% with these synuclein antibodies. And if you have videos of these patients and people look at these videos and provide ratings for them, well, it turns out videos of slowness, stiffness, tremor, the medication reduced progression of that by 35%. And if you just look at bradykinesia, which is slowness, well, that was reduced by about 30%. And they also used a phone that assessed tremor and movement. And when you looked at that objective measure, the medication slowed progression by 25%. And ultimately, in the study, everybody went on the real thing for sure. And when it was compared, the medication was compared to patients in a different study who weren't on any medication to slow disease. Well, it looked like the medication, the antibodies, slowed progression 50 to 60%. So none of this is definitive, but it sure is suggestive that this might be the kind of therapy that we're after. So this medication and others like it remain in clinical trials, and I think the future looks really bright for this and other therapies that affect this synuclein process. So to summarize where I've been here on this lecture, what is the problem that patients are facing? Well, synuclein is misfolding and then clumping up, and it's a process that spreads through the brain and the nerves of the body. And that causes long-term problems, especially over the long-term balance and thinking and memory problems. And it's going to be really hard to develop good symptom therapies for that, so we got to be able to identify patients early, way before they have slowness, stiffness, and tremor, and then provide these therapies that slow that process so that hopefully they don't run into long-term disability and hopefully maybe never get slowness, stiffness, tremor. So University of Florida that Adolfo represents, and for me, the University of South Florida, both these universities do clinical trials looking at promising medications to slow progression, as well as looking at new medications to try to treat symptoms. For us, here's our contact information. We are looking at antibodies against synuclein as well as other therapies to slow progression of disease. If you're interested in that, you can give us a shout out. Also, for patients whose levodopa only lasts a short time and they experience off episodes in between levodopa administrations, we have a bunch of therapies for that. And one of the things I'm most excited about is slowing MSA. So if you have MSA, give our centers a call and think about getting involved in clinical trials to try and slow MSA. So that's my look at where we're headed starting now and going into the future. So I'll say thank you so much for your attention. Thanks.